Well, if you've been highly advised about how the health ministry operates, you will definitely be part of this conversation. The hashtag is UBC Frontbench. The phone number, again, will be running on your screen, 0709602592. Now, with the phone number, you can send in your comments and, of course, also the questions that you want the minister and the PS to speak to. And you never know, maybe you'll get those questions answered. However, we should be as respectful as we can as a viewer. Now, I'll start off with the minister. Honorable, I wonder what the mandate of the ministry is and how does it align with the role of the local governments in providing health services?
Well, thank you very much for that question. And I believe it is very pertinent because usually people confuse the mandate of the Ministry of Health headquarters and that of the local governments. Let me state here that our mandate as a ministry, number one, is to initiate policy. I say initiate because these policies must be approved by cabinet, which is the government. We also develop strategies on how we are going to manage our day-to-day issues concerning health, whether it is clinical or public health. We develop guidelines for our health workers to follow in their work. We coordinate the overall sector activities. We carry out support supervision to both the central and local government institutions. We also carry out monitoring and evaluation. And we are at the forefront of managing and coordinating provision of healthcare services for all Ugandans to ensure that they are healthy and productive. So how does this align with the local government mandate? Knowing very well that we have the Constitution of Uganda and also the Local Government Act, which gives the local governments also priority key areas that they manage. So let me start with governance and leadership of the health sector. That, of course, involves a lot of policy making and dialogue with the stakeholders, strategic planning and resource mobilization. So we support the local governments to develop plans that are aligned with the sector priorities. And when I talk about that, we mean that their plans have to be aligned to the national development plans. It has to be aligned to the health sector strategic plan. It has to be aligned to global health agenda, but it also has to focus on the priorities of the ruling government. That is the NRIM manifesto. So every year we supervise the plans that they make and submit for budget allocations. In addition, the Ministry of Health, in reviewing regulations and laws, also disseminates them in working with our agencies or institutions that also support us to run the day-to-day activities together with the local governments. And that includes institutions like National Drug Authority, the professional councils, because they have to regulate the health workers, also in the local governments, and of course including the body that delivers medicines, that is the national medical stores. We also ensure quality health service provision. So we are responsible for the standards and the guidelines that the local governments follow, as well as the facilities that are private and private not for profit. So we guide them in that area. In carrying out our supervision and mentorship mandate and evaluation, we also carry out what we call the annual health sector performance, where we compare performance of local governments to encourage them and also instill a spirit of hard work amongst them. I am sure that many of you have come in touch with what we call the league tables, which gives the performance of the local governments, performance of the sectors, and performance of various health facilities. we are responsible for human resource capacity development, both for central government and local government. Now, what we do is that we carry out what we call a training needs assessment that gives us an idea of how many specialists are required, issues concerning continuous professional development, orientation, refresher courses for both local and central government. But also in collaboration with other health institutions and the local governments, we also support infrastructure development, both central government and local governments, just like what we have been doing in the recent past, upgrading health center 2s to health center 3s. That is part of it. When it comes to outbreaks, we give the guidance and the standards. The local governments actually manage the disease outbreaks. They are responsible for carrying out surveillance and management of the cases. And then we also undertake what we call research, innovation, and development in collaboration with the local governments. Now, in all our functions that we undertake, we do this in collaboration with key partners. Those are health development partners, civil society organizations, academia, the private sector, related ministries, departments, and agencies. Of course, together with cabinet and parliament, because we get our resources appropriated by parliament and the allocations coming from cabinet. So when we talk about local governments, the Local Government Act gives them several mandates, and I will read out the mandates. They are responsible for planning for district health services in line with agreed national health policies. Remember, I said we support them in the planning process. They are responsible for delivery of quality health services. Again, we set the standards that they follow. Resource allocation, financial management, and accountability based on the ceiling that is provided for them. The local governments recruit their own human resources. And when I talk about recruitment, that starts from the district level, the general hospitals, up to the health center 2s. They are responsible. Health Service Commission only provides support and technical supervision. Otherwise, Health Service Commission recruits for the center. The local governments also mobilize resources. They pass specific bylaws related to health. They carry out supervision, inspection, monitoring of the lower level health facilities within their mandate, and are responsible for good stewardship, governance, and leadership in their area. How do we get statistics for accountability? We have what we call the Health Management Information System, where we collect data on a routine basis, and this data is filtered through the district to our district health information system. So every day on a dashboard, we are able to view the performance of each district, including tracking whether there are outbreaks or not. That gives us a quick glimpse into the situation regarding health in the sector.
All right. Thank you very much for that overview. And let me get to the Permanent Secretary. Dr. Diana, when we look at the Ministry of Health, what is, if you can explain to the viewer, its role in delivering health services to the last person, let's say at village level? And again, one may wonder, should the ministry be responsible in case we find any issues at, let's say, health center 3s?
The health sector is delivering services through 3 categories, maybe 4 categories of levels. The first one is the tertiary. At the center, we have tertiary institutions or specialized institutions like Cancer Institute, Heart Institute, centers of excellence, and then we have national referral hospitals. Then we have regional, when you go down to the region, we have regional referral hospitals. And those regional referral hospitals and national referral hospitals are offering more specialized services. And that's when you look at the structure, we'll have specialized personnel, the specialists in all disciplines at national, but also at regional referral. Then when you go down to now those are managed under central government. Now when you go to the local government, the highest facility in the local government is the district hospital. And by policy of government, we're supposed to have one hospital per district. However, some of the districts are smaller, and because we have the criteria, we go by to have a district in each hospital, a hospital in each district. And then when you go down in constituency, we are supposed to have a health center for. In our new structure now, we call it community hospital. So I think in the long run, we may have to move away from district hospital as a requirement, because what we have done now at health center for in our new structure, if we implement it as the community hospital, it means that every constituency will be having a community hospital, and this one will have more human resource than what the current health center force are having. And also they will have more doctors, they will be able to provide more services. The health center 4 is where we deploy the doctors, and they are able to have, they are the first referral from the lower facilities. Then from that, from the constituency, we go to sub-county. As per policy of government, every sub-county is supposed to have a health center 3. Currently, a health center 3 is headed by a clinical officer, and the services that we are providing are the basic primary health services, and also we deliver women and also conduct antenatal services in there. Okay. From there, we go, right now we have health center 2s, but those health center 2s eventually will have to be upgraded, all of them, because as per the directive of the president, he guided that we should concentrate more at health center 3s. Therefore, all those health center 2s will be eventually upgraded. Right now, we still have quite a number of sub-counties where we haven't put the health center 3s, because more sub-counties keep on coming up, but that is the policy. Okay. Now, we have also the community health extension workers that we have introduced at the parish level, 2 per parish. Right now we are in 25 districts, but as we go along, as we continue getting resources, we'll be able to recruit more and train more, and we want to see this cover the whole country. Now we have also the VHT, the village health teams. These are volunteers at the village. So our service delivery, right from the tertiary to the primary health care at the village, that's how we deliver our services.
Okay. And Piers, still with you, there's been an effort by the government through the Ministry of Health to build satellite laboratories in the country. I wonder, though, how have these labs enhanced disease surveillance and improved the speed of diagnostic services, both on national and regional level?
Yeah, as you remember, the time of COVID, this was a wake-up call, and our experience showed that we cannot deal with epidemics without building capacity, and especially in the diagnostic capacity. And since then, we made sure that we expanded the laboratory capacity at the headquarter, or what I would say the central reference labs. We have now increased our reference labs. Now these are the highest level of service, like as you hear, they are reference. We refer the highly maybe sophisticated tests to those those reference labs. But in addition to that, in addition to strengthening the reference labs, we have also established more satellite labs, and these I can just give example among the many. We established Mbarara, Lira, Fort Portal, Mbale, and we are continuing to build these labs. Now these labs are going to help us, and they are actually helping us to enhance capacity of testing for any diseases, that we don't have to transfer. Before we used to transfer the samples all over the country to Kampala, but now the capacity that we have built is helping us to test quickly, get results, and treat. Not only just we are setting up the satellite labs, but we are also accrediting them. We have now over 30 laboratories in the country that have been established or accredited by international bodies that meet the world class status. So this is also one of the strengths that is helping us to deal with outbreaks. Just if I give an example now, just this Ebola we had recently, the strength lies in quick turnaround time of getting the test done, and also having the skill to do highly sophisticated tests using the newest technology, and that's what we are doing. This is continuing. We are not able to cover the whole country right now, but that is our plan.
Okay. And Honorable Minister, the PS mentioned something about COVID. And during COVID and then after the pandemic, we saw huge investment in hospital facilities, and such as, let's say, oxygen plants in regional referral hospitals. So one may wonder, let's talk about the expansion of the ICU capacity and the progress in setting up new facilities across the regions in the country.
Well, first of all, I must say that the COVID-19 pandemic came with its disadvantages and advantages. And the advantages was that there were heavy investments in the health sector. And the health sector will not be the same again. It has grown and expanded. And like you mentioned, one of the fundamental investments to ensure that we have oxygen available, even for the lowest health facility. So every person, whichever health facility you go to, you're able to access oxygen. So government invested in what we call the PSA plants, 100 nanometer plants that fill up to 120 cylinders in 12 hours. And these were installed in all the 18 regional referral hospitals. They were installed in the national referral hospitals, the 5, and also at the national medical stores. In addition, government also invested in liquid oxygen cylinders. So we have 60,000 liter cylinders installed at the national medical stores and also at Mulago. So that in the event that we have challenges with the PSA, which give the gaseous oxygen, we still have oxygen, liquid oxygen that is compacted and we can distribute. So we expect that the lower level facilities, health center 3s, 4s, and general hospitals will be getting cylinders from the regional referral hospitals that serve that region. And to date, all the PSA cylinders have been installed. Government also invested in intensive care unit equipment, specifically for the 17 regional referral hospitals, because we already had intensive care unit equipment in Mulago as well as in Chirudo and the other national referrals. So each of the regional referral hospitals are able to get about 10 intensive care unit equipment that comprise of a bed, a ventilator, a monitor, high flow oxygen therapy device, infusion devices, ultrasound machines, mobile x-rays, and so on, for purposes of managing critically ill patients that will need ICU care. Now, we also went ahead and started construction because that was done in an emergency mode at that time, and many of our facilities did not have the infrastructure to accommodate the ICU equipment. But we tried to install them where we could at that time for purposes of managing patients. Right now we are constructing ICU infrastructure, and we started with Jinja, Kabale, Hoima and Arua that now have the standard ICU infrastructure. But we are also going to construct in the other facilities in a phased manner. What is left for us to do is to ensure that we recruit and deploy specialists, critical care nurses, intensivists, and critical care doctors to these facilities so that they can continue with intensive unit care. However, if you'd like me to continue, there were many other investments. Okay. Those are just two.
When we do return after the break, I do have some questions coming through, quite many, and we shall be getting some of those answered by the Minister and the PS, but on top of it, more of the conversations do return. The hashtag on X is UBC Frontbench. You can as well share your opinions and comment on our YouTube live, but in the same regard, if you cannot access WhatsApp at this time, you can send in via SMS. This is the Frontbench. We return shortly after.
This is the Front Bench. In a nation hungry for truth, a world where every story matters, there exists a beacon of trust and reliability. For decades, they've been our voice and our window to the world, holding the mirror of our history. With 4 TV stations and 11 radio channels spanning 27 languages, they stand as guardians of information, defenders of truth. With Mascari Heritage Advantage, they uphold every citizen's right to reliable and free information. Their archived stories shaped our past and illuminate our present. Yet now, as new challenges arise and the world evolves, their mission faces its greatest test yet. Be part of our journey and let's navigate the unknown, uncover the untold, and safeguard our future together. Tune into your public broadcaster, for it is the intersection of trust and truth. Because to UBC, your story, and every voice matters. UBC, inspiring Uganda.
Welcome, traveler, to the adventure of a lifetime. Rare, beautiful, and precious. Embrace the unique, unforgettable, and extraordinary. Come and explore Uganda, the pearl of Africa.
This is the Front Bench.
All right, good to have you back here on the Front Bench, and the comments and questions keep coming in, I think, because it's the Ministry of Health. Okay, let me first get through some of these comments. There's someone saying, I am watching from Rukunjiri. Thank you for the show. I would like to know, why is it a common practice of the government health centers to send people to pharmacies and clinics? Do the people distributing drugs in health centers lack the medicines? That is a person from Rukunjiri. Then we have a comment coming in from Moses from Iganga. He says, good evening. I have a complaint about Iganga main hospital. There is no x-ray machine and it has almost been 10 years. We've been forced to go to doctors' clinics for those services and it is very costly to the people. And he also mentions that the services in Iganga hospital are very low. Please help us. And the other person is saying, hi, my question is about nutrition and food security. What plan does the Ministry of Health have in regards to addressing the malnutrition and food insecurity in the country? Let's start with those three. I'll start with the Minister on the issue of food insecurity and malnutrition, mainly malnutrition.
Okay, thank you very much. And thank you for the question. Allow me to state here that Uganda is a very beautiful country endowed with good weather. Although, of course, sometimes we get the extremes of very high temperatures and very heavy rains. But on the whole, we have food. However, sometimes because of socioeconomic challenges, people don't store the food. They sell away the food. And sometimes it is because of ignorance. They don't eat the right foods. So we have cases of malnutrition nearly in all the districts, but majorly in northeastern Uganda, where we have high rates of malnutrition in Karamoja sub-region. But we also have malnutrition in southwestern Uganda. How do we manage malnutrition? We have our facilities for taking care of malnutrition, but our aim is to ensure that we prevent. We address the issue of stunting, the issues of wasting, and the issue of severe malnutrition. And we do this by screening the children in our facilities and giving guidance. But the entire Nutrition Action Plan, which is housed under the Prime Minister's office, spells our response to issues of nutrition and food safety as a multi-sectoral issue. And so we manage it holistically as government, with the Ministry of Health handling the aspect of severe malnutrition. The other aspects are managed by Ministry of Agriculture that takes issues of food availability and food security, and the other sectors do what their responsibility is. Now, we have undertaken as a ministry to develop guidelines on the kinds of food that people should eat and the quantities that they need to eat in order for us to have a balanced diet and ensure that we address the issues of wasting, stunting, and malnutrition, severe malnutrition. And this is being disseminated to the entire country through the community health extension workers, who will also be responsible together with the village health teams to teach the population what they need to eat.
Okay. And P.S., I would like you to respond or give a comment to the question from Rukunjiri. Someone has concerns in there saying that many of the doctors keep sending them to private health facilities.
Yeah, it is true that some of people, when they come to facilities, they are told to go and buy medicines outside. Now, I just want to summarize the issue of medicine stock out in 3 ways. The first one is that you find the population that is sick that comes to that facility is more than the medicine supplied. And therefore, at the end of the day, you find maybe the medicines that are supplied to last for 2 months, they last 1 month, and then the rest of the remaining month, before they bring more supplies, people are told to go and buy. Then there is also the issue of the drug theft. We have seen even up to now that we still have that problem, especially in the border districts, where especially when our neighboring places have issues like war or service deliveries affected, then they come and entice our people to get the medicines. So we still have that problem. But also there is another issue, that when it comes to ordering or when it comes to prescription, when they are ordering, sometimes they don't estimate the actual amount of medicines for those particular diseases. And that's why National Medical Stores has been working very closely with the districts to come up with a procurement plan that is nearly accurate, that we are able to estimate and know the need of the facilities. But sometimes it changes. Sometimes you can have outbreaks, or sometimes you can have the diseases that they did not anticipate at that time, and then they get more patients for that period, and they stock up. But also we have irrational practice, irrational what we call irrational prescription of medicines. You find that some professionals have propensity to prescribe particular brand, and you find another brand of the same drug is in stock, but they want the other one, and they leave, and they make sure they send those people. And in most cases, such things happen where people have personal interests and they want to send them to the clinics. We are discussing on how we can even stop having those clinics you find in our hospitals, government hospitals, and you find in the just outside the gate, they put so many pharmacies, so many labs, so many clinics. And those are things that we are discussing to see how we can move, because those are actually a big enticement for people to go and send people outside.
Okay.
Yes.
And Honorable Minister, someone from Iganga mentioned something to do with an X-ray machine that they do not have in Iganga for close to 10 years. And he also shares that the services at the main hospital are really low. What would be your comment on that?
Well, let me just say that we are aware about the lack of X-ray in Iganga General Hospital and many other hospitals across the country. Not that they did not have at all. Some of the X-rays became obsolete. Some of them we can no longer get the spare parts because the manufacturers are no longer there. Those are some of the challenges we experience from time to time with equipment. I want to reassure the population of Iganga that through our support supervision, we have identified these challenges, and we will soon provide an X-ray facility to Iganga. Now, talking about the low service delivery, I don't understand whether it means that very few people go to the hospital, or the range of services provided are quite low. But the range of services provided in Iganga Hospital is commensurate with what a general hospital ought to provide. However, there are some cases where certain specialists are lacking, because in our general hospitals, we allow for the presence of gynecologists, pediatricians, general surgeons, and physicians to give special attention to the patients, including ENT surgeons and others. We have had a challenge in recruiting specialists because of the constricted wage bill, but those will be provided in due course. However, allow me to request the local government to pay more attention to the hospital, because it is a hospital under the local government stewardship, to ensure that services are being run in the manner expected as per our standards.
All right. And before I switch back to the questions that I already have here for the Minister, let me end this bit of the engagement with you, our dear viewer, with a question that will be pointed to the Permanent Secretary. So it says, thank you for the accountability program. I have not heard of the role, I've not heard of the support of the private sector, which plays a key role. Thanks UBC, thanks Honorable and the PS for the spirit of accountability. So he mentions the government support to the private sector, which has gained the trust and confidence of the population. Despite the regulation, how can Ugandans benefit from the private sector and the Ugandan government relationship?
As per our policy, government supports private, not for profit. We know that about 40% or so of the population access their services in the private sector facilities, and the private facilities, we have the ones we call private for profit, and then those ones that we call private not for profit. Government supports budgetary provision to those we call private not for profit. And even in some facilities, we second the human resource to them. We provide them with some money for PHC, and that money goes directly to joint medical store to buy some medicines to support their budget. But at the same time also, we treasure, and government works very well with the private sector. We may not provide, especially those we call private for profit. We treasure their contribution, and we normally collaborate. For example, now, just if I give an example of this Ebola that we had, we brought everyone. We trained the private not-for-profit. We trained private for-profit. We trained our public health workers, because we know for sure that government cannot cover other services, and therefore we continue to work very closely with the private sector. We may not provide adequately, because also on our side we don't have sufficient resources, but we do treasure and we work with them. And even where we are not able to provide directly, we work with the partners and we recommend them to the private, especially the PNFPs, where they support them. They support in terms of human resource, they support in terms of resources, they support in terms of commodities. So we really work with them. So maybe we just didn't mention, but we work very closely with the private sector.
Okay. And Honorable Minister, when you look at the current developments just previously with the outbreaks of Mpox and the Ebola Sudan virus, what are the updates so far, and how prepared are we as a country and the ministry in regards to any future epidemics, both in terms of infrastructure and manpower to combat this in various health facilities?
Let me start with the updates. And I will start with Mpox.
Okay.
The Ugandans seem to have forgotten that we have that outbreak. But again, let me stress that we still have that outbreak of Mpox. And to date, we have seen about 2,896 cases that we have managed in our isolation facility. We have 2,126 that have recovered. Unfortunately, we lost 19 people, and 87 districts were affected or are affected, with some districts only recording 1 case each. The good news is that since we started vaccination, the number of cases are going down, and we are still continuing with the vaccination process. Now, as regards the current Ebola outbreak, which is our 8th Ebola outbreak, we had a total of 9 confirmed cases. The index case we lost. We have 8 cases that we will soon be discharging, and we thank God that we have not lost any. We, because of experience, undertook a very good and quick system of putting all the contacts in quarantine, so we're picking cases from quarantine, and that has made us to control the outbreak in a very short time. Now, when it comes to the systems in place, again, the government of Uganda has been systematically developing systems for preparedness, for response, for control of outbreaks since the year 2000, when we had our first Ebola outbreak in Gulu. And since then, several infrastructures and systems have been put in place. We already talked about the laboratories. We enhanced the laboratory capacity. Now we are able to deploy even mobile laboratories where there is an outbreak, and we call it point of care. Like right now we have a mobile laboratory in Mbale, and those are biosafety level 3 laboratories. And we have also ordered more so that in future we have flexibility in having mobile laboratories everywhere, in addition to the reference laboratories that the permanent secretary talked about. Now, off from the laboratory system, the other systems we have in place to monitor outbreaks are the emergency operation centers that we have in all regions in the country. And we have 18 regions that we call our regions, where the regional referral hospitals are, and we monitor these outbreaks on a dashboard on a routine basis. We have a field epidemiology training program where we train epidemiologists, and we are aiming at an epidemiologist for every 200,000 population. Every year we, graduate field epidemiologists. These are people at master's level who come to train in addition to what they already have, to have that experience of being able to carry out surveillance in the different parts of the country. And they are our strengths, because our diseases need quick surveillance, because time is of essence. We have also factored in health informatics training for data in real time and analysis, and also the laboratory component of surveillance, because laboratory is part of surveillance. Now, the system that we run starts from the village level. And at that level, we have the village health teams trained in surveillance, as well as the CHUs that are based at the parish level, because outbreaks occur in the communities. So when they are detected in the communities. Immediately, they inform the laboratory focal persons who go and remove the samples. So that is our immediate strength, the community surveillance and the communities who actually end the epidemics. Now at the districts, we have the district focal persons and the district statisticians who ensure that we get data in real time, which data is then filtered to Ministry of Health for us to act. Apart from that, of course, we have strong partnerships with our health development partners, and collectively we mobilize resources to help us respond to these outbreaks.
Okay. And PS, let's talk about the issue to do with reproductive health. When you look at the desire for every woman to have health delivery, we wonder how is the ministry taking care of that bit of the sector in order to see that at least the desire of every expectant mother to have safe delivery is highly prioritized, but then also becoming a reality.
Yeah, as per our the policy right now is that we must have a health center 3 at sub-county. Now that reduces the distance, or the long distance that previously these mothers used to travel to go to these facilities. Now that is addressing the issue of access. So every sub-county having a maternity that is well equipped, well staffed, is one aspect that addresses the access, the quick access. As I talk now, about 85% of our population is within 5 reach of the facility. So we for the last 3-4 years, we've constructed over 350 health center 3s. So we have brought nearer the services to the people. Then the second thing is we have a very robust emergency medical services, because one of the reasons why and really we reduced the maternal mortality was quick response to make sure that it responds to the emergencies, especially for those women that are obstructed and are picked wherever they are and delivered to the facilities, especially the referral. And we have started working on this referral pathway to make sure that we follow through, and we make sure that the people that need emergency services are picked in time, and these women, especially women and children, because those are the most vulnerable. So since the question is mainly on the women, we have improved the emergency services, and that also has helped us to improve or to reduce on the mortality and morbidity. But having said that, what we are doing mostly is to strengthen how our health workers approach the reproductive health. And we have been training, and we have we've worked with even partners to make sure that we train all our human resource, especially in the lower units, all the way up to the national levels, to be able to handle the simplest women issue, but also up to the level of specialized center. That's why government set up the Women's Hospital that is providing highest level of care as a referral entity. Apart from that, we also we have improved on linkage to care, because what was missing before, it was our human resource, especially when you are going to refer. Now it is a requirement that if you have a referral that you are going to refer, you must have a linkage to the other person that you are going to refer, so that they prepare. Okay. Before, the people would just go and walk in, or they are referred, but now it is a requirement, so that by the time you get to the facility where you are being referred to, so everyone is prepared, and they receive you, and they handle the issue. The biggest tool and the biggest strength that we believe that is going to change the trajectory of maternal and child health is the community awareness. The community awareness why they need to come for antenatal, the community awareness why they need to embrace family planning, the community awareness why they have to come early, especially when they are risk mothers. So the whole continuum of care, as far as the women's health is concerned, people need to know. People need to know that it is not now good for them to go and attend to traditional birth attendants.
Okay.
Yes.
I want us to also want to pick your comment, PS, on the issue of blood transfusion. What has the ministry done to ensure that there is enough blood for everyone in case of those emergencies that arise, region-wise?
And I think that question is related to the women and children's health, because also when you look at the biggest cause of maternal mortality is PPH, the bleeding. Okay. And one of the commodities that is essential to save mothers is blood. And the access to blood across the country was a challenge, because not many regions could have blood bank. But since then we have started being intentional, and we have started constructing more blood banks. And I think soon we are going to be commissioning Soroti, Arua and Hoima, and soon this year or next year we are starting on Jinja and Lira. So with time we are going to continue expanding and making sure that all the regions have a functional blood bank, not just function as a structure, but to have the human resource, to have the equipment, and to make sure that we have the highest level of standard of care, even at screening the blood, so that the blood is safe, but also it is accessible. That's what we are doing. All right. And Honorable Minister, back to you. If you could tell us more about the construction of emergency call and dispatch centers, their functions, and how they will improve efficiency of medical responses, particularly in the remote areas of this country.
So the emergency call and dispatch centers go hand in hand with the emergency medical services. Under the emergency medical services, we look at the ambulances, we look at the trained personnel, the first responders, we look at the care in intensive care units and the hospitals, wherever they are. So we have call and dispatch centers that are being constructed in a number of hospitals, maybe 4 currently, but we will increase them. Now the call and dispatch centers are meant to coordinate ambulance services in regions. We are distributing ambulances, 1 per constituency. Now, during the COVID period, we managed to procure about 123 ambulances. We also had about 180 type A. We procured type B out of our need of 460 ambulances. So we distributed this to the various constituencies. Some constituencies will need more ambulances. I mean, some regions will need more ambulances than others because of the size of the regions and the number of constituencies. Now, when we just deploy these ambulances there and they are not coordinated, they will not do a good job. So we put up the call and dispatch centers so that anybody in any part of that region, whichever village, can call. And we are working at getting the number 911. So when you call, it links to the call and dispatch center, and the nearest ambulance to you is sent to pick you and bring you to the facility. Similarly, we have ambulances at the regional referral hospitals for purposes of transferring patients to the national referral hospitals or the specialist centers. Now, all these ambulances have personnel that are trained to manage the critical cases, and these are called the first responders. Say, for example, if there is an accident, Ministry of Health works with the police, and these people are trained to ensure that you're picked up very well and in a safe manner, put in the ambulance, resuscitated, and transferred to the place where you are supposed to go. So right now, working in collaboration with the Uganda Red Cross, we have deployed ambulances along all the highways. That is why you see a very quick response whenever there is an accident or a fuel tanker bursts somewhere or so on. The ambulances congregate there and pick the victims as quickly as possible with these emergency medical teams ready on hand. Okay. So our aim is to ensure that every region in the country has a call and dispatch center that will be linked to the national call and dispatch center, which will be at Naguru National Referral Hospital, so that our referral system is well connected to where the patients need to go.
All right. Now, since our time is fast spent, we're going to be having the parting shots from my 2 guests this evening. I'll start off with the PS. PS, I would like to take your comment on how the ministry is adapting to the funding suspension of some of its programs and projects following the executive order issued by the United States President Donald Trump. But then also, if you can, still in your parting shots, we've seen a circular to all health facilities in the country directing them to integrate HIV/AIDS services in routine or other services. If you can elaborate on the same, as we call it a day.
At the moment, I think at the beginning, yes, there was some bit of shock, but I think later we received communication that they're opening up, and I think the services are continuing to be provided. The ARVs are given to the people, the health workers that had been stopped, they are back to work. However, we do believe that this is also, it was an eye-opener for us, and we need to strengthen our systems by looking at how we can do it in a manner that is efficient. Because what we saw previously with our partners, it was more, in some areas we would see a lot of verticalization of services. But now we want to take this opportunity with these few changes that are happening to consolidate and make sure that we don't just have separate clinics here, then one side of the facility people have nowhere to go, then here it is only for HIV. So no, we wanted really to consolidate these services so that we have a well integrated way of doing things. And that way we do believe that it will bring it will bring efficiency because we will optimize what we have in the facility, we'll optimize resources properly. But also, I believe that it is also a wake-up call for us to start looking at how we can build resilient systems as a country, how we can budget and prioritize some of the things without depending on partners, and how we can provide services in an efficient, integrated manner.
All right. Thank you very much for your time, PS. And to the Minister, as we're summing up in your parting shots, with the ongoing developments surrounding the Loboa Specialized Hospital, if you can provide an update on the current status of the hospital construction and on the readiness of the same facility.
Well, I know for a long time the population have been yearning to know what is going on at Loboa. Allow me to inform you that the construction at Loboa is going on. We are already on the 6th floor and roofing is taking place. We are on progress to partially ensure that the hospital could actually function by the end of this calendar year if all goes as planned. If all does not go as planned, then we are looking at early 2026 for the hospital to open up and begin functioning. So I want to state here that the construction is on course, the workers are on site, and in spite of the challenges that we went through with the COVID-19 and the lockdowns and the challenges in getting resources on time, Loboa will finally open up.
All right. Thank you very much. And there you have it, dear viewer. The Honorable Minister, Dr. Jane Ruth Acheng, and the Permanent Secretary, Dr. Diana Twine, have been part of the discussions tonight, looking at the Ministry of Health. And, well, of course, this engagement with the Ministry of Health will continue with other proceeding shows. But it is at this particular moment, I should as well say that for the past 4 months of the running of this show, I'm rather very grateful to have been the pilot leading the conversations. And tonight marks my final episode as the host of the show. So next week when the conversations return, the Monday night conversations, we shall have a different face, but rather a familiar one. The gentleman just standing behind me here holding a piece of cake. So I would definitely say I'm really grateful to you, the viewer, the production team that have walked this journey and supported me throughout leading the conversations here on the front bench. And hey, continue watching the front bench every Monday, 8:30 p.m. here on your national broadcaster. For JP Live and Joram Paul Sonko, the journey on the front bench.
Before you say bye-bye, well, my role is very simple.
Okay.
I am here to appreciate you for the good work you've done for the national public broadcaster. You've been a very good transformer. You have been a very good team player. From me and the entire team, I want you to join me, cut this cake as a way of appreciating the good works you've done for us.
All right. I'm not so good with the colors, but I would definitely tell you I do love the colors chosen for this particular cake and the entire management. So let me just be part of this. But for you, our dear viewer, thank you very much for being part of the show, from where we started with the Ministry of ICT and National Guidance.
All right. Please, come this side, all right? Come this side, this way, all right? To the entire team, thank you so much for being part of us.
Good evening.
Thank you.
This